In this introductory video about skin cancer, we are going to talk about the classification scheme for the most common skin cancers, which include squamous cell carcinoma, basal cell carcinoma, and melanoma. Dermatology can often feel like a lot of memorization, but I hope you'll be able to see in this video series how skin cancer in particular can be understood rather than memorized by understanding the relationship between histology and the gross clinical appearance of lesions. So to do this, I want to start with the basics and then move our way from there. So to do this, I've brought up a 3D image, a 3D cartoon histological image of the skin to remind us of what the three main skin layers are. So starting up here at the top, the very topmost layer, I'll remind you, is the epidermis, which provides us with barrier protection. And below the epidermis, in light pink here, is the dermis, which contains fibrous and elastic tissue, giving our skin flexibility and strength. And it also contains blood vessels, nerve endings, and hair follicles, as you can see here, which are actually an appendage of the overlying epidermis, as you can see here. But finally, below the dermis, we have the subcutaneous fat, often referred to just as the sub-Q layer, which provides us with an energy store and insulation. And the reason that I just wanted to remind you of these three skin layers is because it turns out skin cancer can originate from any one of them. But we want to focus specifically on the epidermis because it turns out that the most common types of skin cancers originate specifically from this layer. So we want to go ahead and zoom into this layer further. So let's go ahead and zoom specifically into this portion of the epidermis right here. So zooming in, you can now see each layer or stratum of the epidermis, and we won't go through each of these layers in detail, but I'll go ahead and remind you and orient you to say that at the bottom, directly overlying the dermis, which is highlighted here in this light pink color, is the stratum basale, also more colloquially referred to as the basal cell layer, which is highlighted here in red. At the very top, the most outermost layer of the epidermis facing the outside world is the stratum corneum here at the top. And just for comparison, I wanted to include alongside this an actual H&E or hematoxylin and eosin stain of the epidermis and dermis, so you can see what each of these layers looks like on an actual H&E stain. Now, the reason I bring all this up is that it turns out that this can give us a very intuitive way to classify skin cancer. And to do this, we really only need to answer one simple question, which is, what cell type does the skin cancer originate from? And there are two main cell types that we want to talk about in this context. So the first cell type is the keratinocyte. And the keratinocyte is the most common type of cell in the epidermis. It makes up essentially the bulk of the epidermis. And it starts off in the basal cell layer here as a stem cell and then differentiates as it goes through the different layers of the epidermis until it reaches the very top here in the stratum corneum, which remember is just a bunch of dead epithelial cells filled with all of this keratin, which I think is more easily visualized here on the H&E stain. Just for comparison, I'll circle a couple of keratinocytes here on the H&E stain as well. The second cell type that we're interested in is the pigment-producing cell called the melanocyte. And melanocytes are typically located at the dermal-epidermal junction, which is just a fancy way for saying in between the dermis and the epidermis. So they're located along this basal cell layer in red, and the cartoon image is highlighting a melanocyte in this purple cell that I'm circling here. And if you notice, this cell looks a little bit architecturally different than the surrounding keratinocytes, and it has these finger-like projections, which allows it to distribute the melanin that it produces to the differentiating keratinocytes, giving the skin its pigment. Now, if we jump over to the right to our H&E stain, this cell right here in the basal cell layer strikes me as a melanocyte, and it's a little difficult to appreciate the finger-like projections on this particular stain, but the fact that it looks pretty structurally different than these keratinocytes that we circled earlier, and it's located on the basal cell layer, clues me into the fact that it looks like a melanocyte. Alright, so with that histology mini lesson, the big takeaway point that I want to make is that if skin cancer originates from a keratinocyte, we simply call it keratinocyte carcinoma. Simple enough, right? On the other hand, if skin cancer originates from a melanocyte, we call it melanoma. And as an aside, you might be wondering why we don't call this simply melanocyte carcinoma. And the reason is because carcinoma describes cancer of an epithelial cell. Melanocytes are actually not epithelial cells. They're derived from neural crest cells, hence why we call it by a slightly different nomenclature of melanoma. But all details aside, keratinocyte carcinomas and melanomas make up the most common types of skin cancer. Now, it turns out that when it comes to classifying keratinocyte carcinomas, there's one more subdivision that we need to be aware of. And the way that keratinocyte carcinomas are subdivided are as such. So, if keratinocyte carcinoma arises from any of the keratinocytes in the basal cell layer, we call it appropriately basal cell carcinoma, or BCC for short. On the other hand, if keratinocyte carcinoma arises from any of the keratinocytes above the basal cell layer, so the stratum granulosum, spinosum, etc., we call it a squamous cell carcinoma, or SCC for short. And the way that I remember this is that squame literally means scale. And remember that we're getting essentially more scaly as we move up towards the stratum corneum because we're accumulating all of that keratin. Another way to remember that is that squamous cells are often the term that's used to describe these outer epithelial cells of the epidermis. Now, the last thing I want to touch on to hopefully tie all of this together is a little bit of epidemiology. So, keratinocyte carcinomas are the most common types of skin cancer. Depending on where you look, one figure that's commonly cited is that they account for about 97% of all skin cancers, while melanoma, on the other hand, accounts for about less than 2% of all skin cancers. But what's interesting is that the mortality attributed to each of these cancers is inversely proportional to its overall prevalence. So to illustrate this, it turns out that about 80% of deaths due to skin cancer are due to melanoma, or I should say are from melanoma. So you can see that it can be a very deadly skin cancer. On the other hand, keratinocyte carcinoma is generally pretty curable, especially when it's caught early. However, that's not to say that it can cause, in some cases, a not so insignificant amount of morbidity for patients. So with that concludes our introductory video on skin cancer, and I'll just leave you with one final word, which is that you might have noticed that 97% plus less than 2% does not equal 100%, and unfortunately it turns out there are other cell types in the skin that can give rise to skin cancer that we didn't get the chance to talk about. But the key takeaway again is that the most common types of skin cancer, the keratinocyte carcinomas and melanomas, arise from a keratinocyte and melanocyte respectively. This video is an introduction to the histology and clinical features of keratinocyte skin cancers, which include basal cell carcinoma, BCC, and squamous cell carcinoma, SCC. The goal of this video is to make histological clinical correlations for squamous cell carcinoma and basal cell carcinoma. And to do this, we're going to start off by describing what these lesions look like histologically, and then link that directly to what these lesions look like clinically. So let's go ahead and do that first for squamous cell carcinoma, and then we'll do the same for basal cell carcinoma. So to start us off, I wanted to start off with a cartoon image of what this cancer looks like histologically. And before we describe the details, just to orient you, this darker tan color here at the top with all of these cells represents the epidermis, and then below it in this lighter tan color is the underlying dermis, and these blue and red circular structures are meant to indicate blood vessels. And you can probably see in the middle of this image is where kind of the real abnormality is, and this represents the squamous cell carcinoma. But before we describe that, I wanted to kind of draw your attention to a normal span of epidermis here at the left, because I think by describing what normal is, we can have a better appreciation for what abnormal is. So notice here we have an orderly progression from the bottom of the epidermis, which is the basal cell layer, all the way up to the top of the epidermis, the stratum corneum at the top. And this is in direct contrast to what is going on in the center of this image. And specifically, there are 4 features that I want to call your attention to in this image that distinguish this lesion as an invasive squamous cell carcinoma. So the first thing to note is notice how these keratinocytes are all different shapes and sizes. Some are big, some are small, and their nuclei are also all different sizes and shapes. The cellular irregularity and variation in the size of the nuclei is referred to broadly as pleomorphism. So this is one hallmark feature of a squamous cell carcinoma. A second feature to be aware of is notice in the center that there are simply too many of these keratinocytes. Essentially what we have is diffuse hyperplasia of the epidermis. And histologically, this is often referred to as acanthosis. And one thing to note about acanthosis is that it's always relative to where you are in the body. So for example, the epidermis on top of your eyelid is very thin, but the epidermis in the palms and soles of your hands and your feet are much thicker. And so what might be a normal thickness in one part of the body might be an abnormal thickness of epidermis in another part of the body. So it's always important to know that it's relative. But in this case, relative to the normal span of epidermis we highlighted, there's clear hyperplasia or acanthosis in the middle of the image. Now, it turns out that the hyperplasia that occurs in the uppermost part of the epidermis, mostly in the stratum corneum, is also given a special name. Specifically, it's referred to as hyperkeratosis, which is just a fancy way of saying that there's hyperplasia of the keratin-filled cells up at the top. A third feature to call your attention to is notice here at the bottom we have clusters of atypical keratinocytes that have invaded into the underlying dermis. And this is a hallmark feature of invasive squamous cell carcinoma. And invasive simply refers to the fact that these atypical cancerous keratinocytes have invaded past the basement membrane, which underlies the bottom of the epidermis, into the underlying dermis. Notably, it's this feature of invasion past the basement membrane into the underlying dermis that makes invasive squamous cell carcinoma distinct from another similar lesion called squamous cell carcinoma in situ. Squamous cell carcinoma in situ is what is often referred to as an intraepithelial neoplasm. In other words, a neoplasm that's confined to the epidermis. So just to kind of summarize all of this, essentially in a squamous cell carcinoma in situ, you would see many of the features we talked about earlier, like the pleomorphism, acanthosis, maybe even a little bit of hyperkeratosis, but you would not see invasion past this basement membrane into the dermis as we see with invasive squamous cell carcinoma. And now finally, the last feature that I just want to call your attention to is notice how there are these speckled dots drawn in the dermis around these blood vessels, and these are just meant to represent an infiltrate of inflammatory cells, with the idea being that the body is trying to mount an immune response against the atypical cancerous keratinocytes. And in fact, this is a common theme that you'll see for many of the skin cancers that we'll talk about, which is there's often an inflammatory infiltrate of cells associated with these lesions histologically. So now that we've used this cartoon image to build a framework of understanding, the next step is to look at an actual hematoxin and eosin stain, or H&E stain, of a squamous cell carcinoma. So here is a 2D histological slice of a squamous cell carcinoma, and just to orient you, up here at the top in this dark pink stain is the stratum corneum, which, if you recall, mostly consists of keratin and is the uppermost layer of the epidermis. And then directly underlying it, these cells here in lighter purple represent the remainder of the epidermis. And the first thing that might strike you is that you can notice that there is wide variation in the overall thickness of the epidermis. And essentially, what we're seeing here are areas of acanthosis. So notice here we have diffuse hyperplasia of the epidermis. Normally, the epidermis should be a much smaller thickness, maybe something like this, but instead we're seeing some clear diffuse hyperplasia or acanthosis. In addition, we're also seeing some hyperplasia of this stratum corneum layer, and this was what we gave the name hyperkeratosis to in the cartoon image. Now, admittedly, it's a little bit harder to appreciate the pleomorphism or cellular irregularity in the epidermis since we're a little bit more zoomed out here than we were on the cartoon image. But one feature that should be readily apparent to you is that you can notice that there are clusters of atypical keratinocytes that have invaded into the underlying dermis, which is the hallmark of this being an invasive squamous cell carcinoma. And in addition, the hazy blue sea of cells that we mostly see in the dermis, so I'll circle kind of a cluster of cells here. So these hazy blue cells, which are a little bit hard to see, but are diffusely located in the dermis, represent an inflammatory infiltrate of cells that we saw in the cartoon image as well. And then finally, something that's probably staring you in the face, but that we actually did not talk about in the cartoon image, are these hypereosinophilic clumps in the center of the image. So what might these be? So I'll remind you that eosin, one of the dyes in the H&E stain, is a acidic dye. It's a red acidic dye that stains basic structures such as proteins. And remember that keratin is a protein, and in fact these hypereosinophilic clumps, which stain bright red, are essentially staining keratin that's being produced by atypical keratinocyte cells in the squamous cell carcinoma. And histologically, they're often referred to as something called keratin pearls. And they can be a useful diagnostic marker when diagnosing squamous cell carcinoma histologically. All right, so with that histological overview, the next step is to take a look at what the squamous cell carcinoma looks like clinically. So here is an image of a squamous cell carcinoma. But before we describe the lesion, I just wanted to point out that the surrounding skin in this individual is rather atrophic, rather thin, and even hyperpigmented in some areas, as I'm indicating here. And all of this can be a sign of chronic sun damage, which notably is one of the most important risk factors for the development of a skin cancer. And so already this clues us into the fact that the lesion we are seeing here may very well be a skin cancer. And so how might we describe this skin lesion? I might go ahead and describe this as a scaly papule with surrounding redness or erythema. Now, the first question to ponder might be, what accounts for the accumulation of all of this scale on the top of the lesion? And to answer this, let's return to what we saw histologically. So remember that we noted there was hyperplasia of the stratum corneum, which we referred to as hyperkeratosis. And all of this accumulation of keratin, essentially, is what accounts for the appearance of all of this scale on the top of the lesion. So that's kind of a neat histological clinical correlation to make for this lesion. Another thing to note about this lesion is that there are areas that look a little bit more friable than other areas, maybe like here and here and here. And what accounts for this kind of friability is thinning of the epidermis in some regions. So if you remember back to our histology, there was wide variation in the thickness of the epidermis. So in some areas we had very thin spans of epidermis, and then in other areas we had much thicker spans of epidermis, or the acanthosis. And so these areas of thinner epidermis is where you can see some friability, and sometimes in poorly differentiated squamous cell carcinomas, you can even have erosions or ulcerations, which can expose the underlying dermis and make the lesion look even more friable. And finally, the last histological clinical correlation I want to make for this lesion is with regard to why we see this redness or erythema associated with the lesion. And this goes back to what we saw again histologically, this time with regard to the inflammatory cells that we noted alongside the lesion histologically, largely in the dermis. And it's these inflammatory cells that can mediate the processes of inflammation. So for example, leading to dilation of blood vessels and therefore the appearance of erythema or redness at the skin surface, which we see clinically in the lesion. All right, so that sums up our histological clinical correlations for squamous cell carcinoma. And now let's go ahead and do the same exact thing for basal cell carcinoma, and this time it's going to go a little bit faster now that we have our thought process all mapped out. So once again, let's go ahead and start off with a cartoon image of a basal cell carcinoma. Notice that we again have hyperplasia of the epidermis, but this time the hyperplasia that we're seeing is due to the proliferation primarily of this basal cell layer of the epidermis here at the bottom. And I want to take a minute to talk about why the cartoon is illustrating the cells in this way. So the first thing is, the reason why the basal cell layer cells have very prominent nuclei is because as stem cells, these cells are capable of self-renewal, and the daughter cells go on to differentiate through the various layers of the epidermis until, of course, they become the stratum corneum up at the top. And as they differentiate toward the top of the epidermis, the nuclei get much smaller until they essentially almost entirely disappear and the cell is filled with keratin. So that's why the cells at the bottom in the basal cell layer have the most prominent nuclei of all of the layers in the epidermis. And the second point to make is that the reason this cartoon is highlighting these cells as having kind of prominent blue nuclei is because remember that the hematoxylin dye in the H&E stain is a basic blue dye that stains acidic structures like RNA and DNA found in the nucleus. And so that's why the blue hematoxylin dye is visualized primarily in the nucleus of cells and why we see this kind of vibrant purplish blue color of this layer of cells. And then finally, I also want to note this cluster or nest of basaloid cells here, which has invaded into the underlying dermis, signifying that this is an invasive basal cell carcinoma. All right, so now let's go ahead and take a look at the actual H&E stain. So here's a 2D histological slice of a basal cell carcinoma, and once again, just to orient you, up here at the top in this very dark pink color is the epidermis, and then below it in this lighter pink color is the underlying dermis. And I want to call your attention to these basaloid nests that we're seeing in the dermis, just as we saw in the cartoon image. So I'll go ahead and circle a couple of small ones here. You can see a little bit of a bigger one down here at the bottom. And then, of course, this large, well-demarcated nest of cells in the dermis here. And notice that these cells have very prominent blue nuclei, cluing us into the fact these are basaloid cells, which in this case are proliferating atypically in these basaloid clusters within the underlying dermis. Now it turns out there are a couple more histological features that can be useful diagnostic clues when diagnosing basal cell carcinoma. So the first thing is something called a retraction artifact, and that refers to this white gap between the basaloid nest and the surrounding dermis. So that white gap is due to, as the name implies, an artifact that's produced when the slide is being prepared and stained. And essentially what happens is that the dermis around the basaloid nest just retracts a little bit, creating this white gap. And so the important point to emphasize here is that the retraction artifact is not due to the cancerous cells themselves, but rather an artifact of the staining process. And the second thing that can be a useful diagnostic marker is the phenomenon that's known as peripheral palisading. And this phenomenon describes the fact that cells on the periphery of these basaloid nests tend to be arranged in a very linear way. And so as I'm circling here, you can see that the basal cells are just lining up in a very neat formation, essentially tightly enclosing the cells within them away from the surrounding dermis. So this is a phenomenon, once again, called peripheral palisading, and it's a term that pathologists might use when they're describing a basal cell carcinoma. All right, so now I think we're ready to see what this lesion looks like clinically. So here is an image of a basal cell carcinoma, and specifically this is a nodular basal cell carcinoma. And it's important to note that there are several subtypes of basal cell carcinoma, but nodular is the most common, and so we're going to focus on that subtype. And I just want to point out that these 4 black dots around the lesion here were marked on the patient by the dermatologist just to highlight the lesion, but we'll go ahead and ignore these spots as we describe the lesion. So how might we describe this lesion? I would go ahead and describe this as a papule, specifically a papule with a shiny, almost translucent surface and a central indentation within which looks like there might be an erosion or ulceration. And then on the outside, notice the borders are really smooth and almost rolled like a donut. And then it's a little bit harder to see this, but there's also a dilated blood vessel on the surface of the lesion. I'll go ahead and circle it right here. And this has a special name. It's called a telangiectasia. And it is often found on these basal cell carcinomas, which tend to be very vascular cancers. And it's hard to see if there's a blood vessel on this histology stain, it's possible that this up here is a blood vessel, but hard to say if that's what we would actually be seeing on the lesion itself. But suffice to say, a telangiectasia is a hallmark feature of many nodular basal cell carcinomas. One important histological clinical correlation to make for this lesion is actually what's not there, at least compared to what we saw for the squamous cell carcinoma. So if you remember, for the squamous cell carcinoma, we saw that the lesion had a lot of scale, but this time we're not seeing much scale. So why is that? So if you remember, going back to the histology, remember we didn't see much epidermal change. Rather, most of the pathology was in the dermis, where we had accumulation of these basaloid nests. And so because we don't have a lot of epidermal change, we don't see a lot of scale. On the other hand, this kind of raised papular, almost nodular appearance is due to the accumulation of these basaloid nests within the dermis. Now, over time, what can happen is as these cancerous cells continue to grow and proliferate, they can actually outgrow their blood supply, and in doing so, necrosis or cell death can ensue. And in part, that is reflected in what's going on in the center of this lesion. This erosion in the center of the lesion can represent the necrosis that's occurring as the cells outgrow their blood supply. This central erosion or ulceration is commonly referred to as a rodent-like ulcer because it is supposed to look as if a rodent, like a rat, took a bite essentially out of the center of the lesion. So that's a fun fact that you can take away from this video. So that wraps up our discussion of the histological clinical correlations for basal cell carcinoma. And now at the end of the video, I hope you now have a greater appreciation for why keratinocyte carcinomas look the way they do based on what we see going on in histology. This is an introduction to the histology and clinical features of pigmented lesions, including benign nevi, dysplastic nevi, and melanoma. When I was first learning about pigmented lesions, I remember that I had a tough time wrapping my mind around the distinction between nevi and melanoma. And remember that nevi is just a fancy term for moles. And so in this video, I want to talk about the clinical and histological distinctions among benign nevi, dysplastic nevi, and melanoma. Now, one big point that I want to make right from the start is that notice here that I've written these lesions quite suggestively from benign nevi here on the left to the more malignant melanoma on the right. However, it's best to view this simply as a phenotypic spectrum of lesions rather than a causal pathway. That is to say, while it's possible for more benign lesions to transform into more malignant lesions, more often than not, these lesions arise independent of one another. And so, for example, while some dysplastic nevi, which are what patients commonly refer to as funny-looking moles, can transform into melanoma, more often than not, melanoma arises de novo or on its own. So with that big picture overview, let's jump right into the histological distinctions among these lesions. And to do that, I'm going to bring up two cartoon images. The image here at the left is a cartoon histological slice of a benign nevus, and on the right here we have a cartoon histological slice of a malignant melanoma. And before we talk about the specifics, I just want to orient you to what you're looking at. So here I'm highlighting the dermal epidermal junction, and above this dermal epidermal junction is the epidermis in this darker tan color, and below it is the dermis in this lighter tan color, which also contains the blood vessels, which are highlighted with these red and blue circles. And notice these brownish cells. These brownish cells represent the melanocytes, the pigment producing cells in the skin. And what I want to call your attention to is notice that these melanocytes are no longer confined to this dermal epidermal junction where they're usually located. Instead, these melanocytes are forming clusters, and these clusters are found in the epidermis, at the dermal epidermal junction, as well as down in the dermis. So now that you're a little bit more oriented to what you're seeing, let's go ahead and build a framework by which to compare these two lesions. And the framework that we're going to use here is to compare these lesions on three different histological features. And the first feature that we're going to look at is the overall architecture of the lesion. And by architecture, I simply mean how these melanocyte clusters are arranged in the layers of the skin. So here in the benign nevus, I'm simply circling the arrangement of melanocytes. And I want you to notice that the arrangement is fairly symmetric. So these melanocyte clusters are distributed fairly symmetrically within this lesion. And these individual clusters of melanocytes are fairly well demarcated and arranged in a very orderly fashion, which is in contrast to what's going on here in the melanoma. So notice here that these melanocyte clusters are arranged in a fairly asymmetric distribution, as I'm circling here. And moreover, these individual melanocyte clusters vary in shape and size. So we have some smaller clusters, and then we also have some larger clusters of cells. So we can say that the overall architecture is a bit more irregular in the melanoma. Now, the second feature to compare these two lesions on is the degree of cellular irregularity, or atypia. And so let's go ahead and start with the benign nevus. So notice here that these melanocytes are fairly similar in shape, and the nuclei are all the same size, which is in direct contrast to, again, what's going on with this melanoma. So notice here that these melanocytes are all different shapes and sizes. Some are big, some are small, some are oval, some are round, just to give you the sense that the size and the shapes are very different among these cells. And moreover, these nuclei in black are also different sizes and shapes. And so the term that's often used to describe this phenomenon is pleomorphism. And so people will often refer to this as the fact that these melanocytes are pleomorphic along with their nuclei. All right, so the last feature we're going to look at is the degree of stromal response, which is just a fancy way of saying the degree of inflammation that accompanies the lesion. And the way the cartoon highlights this is, notice here these speckles down here in the dermis of the malignant melanoma. Well, these represent inflammatory cells, or an inflammatory infiltrate that is accompanying these atypical melanocytes that are invading into the dermis. And while they're often present in melanoma, they're notably absent or very minimal in nevi. Now at this point, you might be wondering, where do dysplastic nevi fit on this histological spectrum from benign nevi to melanoma? And suffice to say that dysplastic nevi are somewhere in between the histological features discussed for the benign nevi and melanoma. That is to say, when comparing these lesions on those three features we talked about, the overall architecture, the cellular irregularity, and the degree of stromal response, dysplastic nevi have irregularity somewhere in between that of a benign mole and a malignant melanoma. Now, histologically, there are more specific definitions that are used to distinguish these three lesions, but just for the purposes of giving you a broad overview, we won't get into the nitty-gritty of those definitions in this video. However, before we move on, there's just one more point of clarification that I'd like to make, and it actually has to do with something that tripped me up when I was comparing these lesions to what I had learned for keratinocyte cancers, so the squamous cell and basal cell carcinomas. So if you remember, for those cancers, one of the hallmark features was invasion past this basement membrane here of the atypical keratinocytes into the underlying dermis. And so by that definition, you might be wondering, well, if we have invasion past the basement membrane of these, melanocyte clusters, why are we still calling this benign nevus benign? And I think the best way to understand this is to take a moment to talk about how we believe nevi originate and compare that to how we believe melanoma originates. So let's go ahead and start with nevi. So recall that melanocytes are derived from neural crust cells, which migrate from below the epidermis through the dermis to the dermal-epidermal junction. Now, it's believed that nevi arise due to aberrant migration somewhere along this pathway. So you can imagine that if these melanocytes got stuck in the dermis, dermal-epidermal junction, or even up here in the epidermis, they could form these clusters in each of those layers and form these benign pigmented lesions. On the other hand, melanoma is felt to originate from atypical melanocytes at the dermal-epidermal junction, which I'm highlighting here in red. In fact, many melanoma lesions start off with what's called an early horizontal growth phase. And this horizontal growth phase refers to the fact that these atypical melanocytes grow along this dermal epidermal junction. And oftentimes, early in their growth, they can be confined only to the epidermis. And if they're confined only to the epidermis, we call these lesions melanoma in situ. Now, you can imagine that if these atypical melanocytes are just confined to the epidermis or are very early on in their horizontal growth phase, such that very minimal or not a very significant amount of invasion into the underlying dermis has occurred, that the prognosis for these lesions is actually pretty good by simple excision with margins. However, unfortunately, melanoma likes to spread, and it likes to spread fast. And so what often happens is that after this early horizontal growth phase for most melanomas, what ends up happening is that there's a vertical growth phase into the underlying dermis, which I'm highlighting here in blue. And so when these atypical cells then invade into the dermis, the prognosis worsens. And in fact, there's a specific measurement that's often taken called the Breslow thickness. I'll go ahead and write that. So Breslow thickness, and we're not going to worry about this specific definition, but essentially what they do is they measure from a place in the epidermis to the point of deepest invasion into the dermis or even below that. And it turns out that that depth of invasion is the most important prognostic factor for these patients. Essentially, the deeper the invasion, the worse the prognosis. All right, so now that we've gone over the big picture histological distinctions among these lesions, let's go ahead and take a look at their clinical appearances. So in this slide here, I have a clinical image for benign nevi, 3 types of benign nevi, and in the center here is a dysplastic nevus, and at the far right is a malignant melanoma. And I want to make a note that in the next video, we'll go over some specific criteria by which you can use to better distinguish benign nevi from dysplastic nevi and melanoma, but in the rest of this video, I just want to go over in kind of broad strokes the differences grossly among these lesions to get you better acquainted with them. So let's go ahead and start here on the left with benign nevi, and then we can work our way towards the right. So when we're talking about benign nevi, there are kind of 3 main groups. And so the first type are nevi that are known as junctional nevi. And these junctional nevi are characterized by a well-demarcated border and a very flat looking appearance with a very even pigmentation. And that reflects the fact that histologically these melanocyte clusters are located primarily in a very symmetric, orderly fashion along the dermal epidermal junction, giving this very pigmented, even tone. The second type of nevi, shown here in the center, are known as compound nevi. And this compound characteristic is due to the fact that if you notice here, there's a central elevation in the lesion, and then more on the kind of outer edges here is the more macular appearing lesion that we saw with the junctional lesion. So having these 2 characteristics makes it compound, and this reflects the fact that histologically the melanocyte clusters are in the dermal epidermal junction, but there are also some in the dermis, which gives it this kind of nodular raised appearance in the center of the lesion here. And then the final type of nevi down here are the dermal nevi. And dermal nevi describes exactly essentially what's going on histologically, which is that the melanocyte clusters are located primarily in the dermis, which gives us this very nodular raised appearance and this kind of lighter pigmented tone. Now, if we jump to the dysplastic nevus in the center, I want to call your attention to the fact that this slightly larger lesion has fairly well demarcated borders, maybe some slight irregularity, more so than we saw with the benign nevi. But also notice that there's a degree of asymmetry. So if you were to draw a line, this lesion isn't as symmetric as these kind of benign nevi, in which if we essentially drew a line in the center of each of these lesions, each of these sides would look fairly identical. And so there's some slight asymmetry, and some could also argue that the color variation in this lesion is a little bit more than what we saw with the benign nevi. So there are areas of darker and kind of lighter pigmentation, more so than we saw with the benign lesions. And then finally, if we look at the far right at the malignant melanoma, it should be pretty obvious to you that there's a lot of irregularity going on. So I'm highlighting here the irregular borders. And notice right off the bat that this lesion is fairly asymmetric. I don't even have to draw a line down the lesion for you to visualize it because it's so readily apparent. And then another striking feature is that there's a lot of color variation. So notice here that kind of in the center of this lesion here, there's almost a region of whitish, kind of very light brown. And then in other regions, there's kind of a more darkly pigmented tone. And again, here's a little bit of more whitish color here. And so all of this clues you into the fact that there's some abnormality and potentially a malignant process going on histologically. So to wrap up, I just want to remind you to keep these distinctions among these lesions in mind as you watch the next video, in which you'll be introduced to a pretty neat mnemonic that helps you distinguish benign nevi from more dysplastic nevi and melanoma. This video reviews the ABCDE principles, in which each letter stands for a different feature that can be useful in distinguishing potentially malignant pigmented lesions from more benign pigmented lesions. In the final part of the video, we'll review a clinical histological correlation for melanoma, and then talk briefly about the 4 main subtypes of melanoma. In this video, I want to start off where we left off in the last video, and now give you a more systematic way to help you clinically differentiate benign nevi from more potentially malignant lesions like dysplastic nevi and melanoma. So it turns out that there's a very easy to remember mnemonic that helps dermatologists, primary care doctors, and even patients more systematically be able to differentiate benign pigmented lesions from more malignant pigmented lesions. And this mnemonic is known as the ABCDE mnemonic. And as you can see, each letter stands for a different characteristic, and each of these characteristics are essentially red flags that clue us into a potentially malignant process that might be going on in a pigmented lesion. Now, of course, one of the caveats to using such a simple framework like this is that not all dysplastic nevi or melanoma are going to have A, B, C, D, or E characteristics. However, because this is such an easy mnemonic to keep at the back of your mind, if you do come across a pigmented lesion with one or more of these red flag features, it's worth a second look, either by getting a trained eye to take another look, or even potentially taking a biopsy, a sample of the lesion to look at histologically. Alright, so now I think the best way to cement these A, B, C, D, E features into your mind is to go through each of these in turn. So let's go ahead and start with A for asymmetry. So starting off here on the right with this malignant melanoma, if we were to draw a line of potential symmetry through this lesion, you could already note that both sides of this lesion don't look identical. Essentially, if we flipped the lesion onto itself, it would not be a perfect match, and so therefore we say this lesion is exhibiting a high degree of asymmetry. This is in contrast to the benign nevi on the left side of the image. Notice that if we were to draw a line of potential symmetry down each of these lesions, there's essentially almost perfect symmetry. Now the dysplastic nevus in the center is somewhere in between. So if we were to draw a line of potential symmetry here, we can see that it's slightly more symmetrical than the malignant melanoma, but there are also regions of the lesion that wouldn't match perfectly with the other side, so it's slightly more asymmetrical than the benign nevi. Now moving on, B stands for borders, and we want to make sure that we don't miss out on any irregular borders in a pigmented lesion. So going back to our malignant melanoma, notice here how the borders of this lesion are extremely irregular, which is in direct contrast to the kind of well-demarcated borders that you can see here for all the types of benign nevi. Now once again, the dysplastic nevus in the center of the image is somewhere in between. So notice here how the borders are fairly regular, but ever so slightly more irregular than we saw for the benign nevi. The next thing to be aware of is the color of the lesion, and specifically, the red flag feature is color variation within a lesion. So I want to remind you, if we go back to these benign nevi, notice how each of these nevi are different colors from each other, which is due to the fact that the melanin the melanocytes are producing are at different levels within the skin. However, within each lesion, notice that the color is pretty homogeneous. This is in contrast to what we see for the malignant melanoma, where we have patches of very dark pigment and then also patches of lighter pigment. And so it's this color variation that is a red flag that can signal a potentially malignant process. Now you can also know that there's some slight color variation in this dysplastic nevus here in the center, but to a lesser degree than what we're seeing for the melanoma here at the far right. Now, if you do identify color variation in a pigmented lesion, there are 3 colors that are particularly worrisome, and those are red, white, and blue, the colors of the American flag. Red is worrisome because it can indicate irritation or inflammation in the region of the lesion, which can often accompany melanoma. White is also a worrisome color, and just to give you an idea of what this looks like, if we go back to our melanoma here on the right, notice here that there are areas of white patches within the lesion. This is a phenomenon called regression. Essentially what's happening is that the body is mounting an immune response in response to the atypical cancerous melanocytes. And so these areas of white essentially represent areas that have been scarred over by the underlying inflammation. Finally, another color to keep your eye out for is the color blue, and the reason is because melanin deep within the dermis can actually appear almost a bluish hue clinically, and this is due to the fact that shorter wavelengths of light in the blue-violet spectrum are scattered by collagen bundles in the dermis, thus making the lesion look a little bit blue. We don't have any areas of blue pigment for me to show you here in the melanoma, but what I will say is the reason this is worrisome is that if there's a bluish color, it suggests that there's melanin deep within the dermis, which suggests then that there's atypical melanocytes that are potentially invading the dermis as well, thus kind of suggesting there might be a malignant process going on. So moving on, D stands for diameter, and the big idea with this is that the bigger the lesion, the more worrisome it is. And this kind of size cutoff that has been established is that lesions greater than 6 millimeters deserve a second look. And this size cutoff comes from studies that have shown an acceptable level of sensitivity and specificity for the diagnosis of melanoma. One thing to keep at the back of your mind is that 6 millimeters is about the size of a head of an eraser on a pencil. So if you see pigmented lesions that are bigger than that, it might deserve a second look. Finally, let's talk about the last feature of a potential dysplastic nevi or melanoma, which is E for evolution, and this refers to any change that occurs in the lesion. It can be a change in size, change in color, change in symptom. For example, some patients might say that a pigmented lesion started itching or bleeding, and so all of this means that we can't judge evolution by simply looking at a lesion at one time point. It's important either to document how the lesion changes over time through photographs, and or ask the patient about any changes that they've noticed over a period of time. All right, so now that we've showcased these A, B, C, D, E features on gross clinical images, the next thing I want to do is make some histological clinical correlations and remind you that many of these features, these A, B, C, D, E features, have a basis in what's going on histologically. Just as a quick side note, I want to mention that the reason I put E in parentheses here is that evolution, remember, is something that we can't really see in one histological or one clinical image. It's something that we would need to track over time. With that said, we're going to focus on making clinical histological correlations for the A, B, C, and D characteristics, specifically of a malignant melanoma. And to do this, we're going to start off with a gross clinical image and then compare it side by side to its histology. So here I'm going to go ahead and bring up a malignant melanoma. Notably, this lesion has A, B, C, and D characteristics. So starting off with asymmetry, if we were to draw a line of potential symmetry, you can note the marked asymmetry in the lesion. This lesion also has some irregular borders and also has some color variation within the lesion. And notably, if we were to approximate the diameter, it's almost approximately about 10 millimeters or so, which is greater than the 6 millimeter cutoff. So all of these are red flag features that clue us into the fact that this is likely a melanoma. Now, before we jump into an H&E histological stain, I want to go ahead and bring up again the cartoon image of a melanoma to actually remind you of all the asymmetry and irregularity in the melanocyte nests and how they're arranged in the skin. And this is directly reflected in the asymmetry and border irregularity that we saw in the gross clinical lesion. So with that said, let's go ahead and take a look at the actual H&E stain. So here it is, and just to orient you once again, up at the top in this darker purple is the epidermis. The very top represents the stratum corneum up here, and kind of below that is the remainder of the epidermis. And then in this lighter pink color is the dermis. Admittedly, there's a lot going on in this image, but one of my fail-safe ways to approach histology is to ask myself what cell type primarily looks abnormal. And in this case, notice that we have clusters of cells that are producing what seems to be some light brown pigment and also some dark brown pigment, like I'm circling up here in the stratum corneum. And all of these cells represent atypical melanocytes that are proliferating in areas that they shouldn't be. In fact, there are also some clusters of pigment-producing cells down here in the dermis as well. And so all of this together highlights that there's a malignant melanoma. In fact, we can also see another histological hallmark of melanoma in this image. I'm circling here a cluster of what looks like to be inflammatory cells, most likely lymphocytes, owing from their kind of prominent blue nuclei here. And remember that an inflammatory infiltrate often accompanies melanoma. Essentially, the body's trying to mount an immune response against the invading atypical melanocytes. Now, one more clinical histological correlation that I want to make with this image is that notice that the clusters of melanocytes are all producing differing amounts of pigment. Some are producing lots of pigment, some are producing kind of a medium amount of pigment, and some are producing very little pigment. And this variation in the amount of pigment that these atypical melanocytes produce correlates with the color variation that we often see in the growth clinical appearances of these lesions. And with that, let's go ahead and wrap up our discussion of the histological clinical correlations for melanoma. And in the final part of the video, I want to walk you through the 4 main subtypes of melanoma. Notably, the subtypes of melanoma have been classified based on clinical and histological features and don't give us much more added prognostic value. In other words, knowing one subtype from another doesn't give us much more prognostic information. In fact, the most important prognostic factor is independent of subtype and is something called the Breslow thickness, which essentially measures the depth of invading melanocytes. However, for diagnostic purposes, it can be helpful to be aware of the 4 main subtypes of melanoma. So for that reason, let's go through each of these subtypes briefly in turn. So starting here on the left with superficial spreading melanoma, this is the most common type of melanoma. It accounts for about 60 to 70% of all melanomas and typically appears as a pigmented plaque. And as you can see in this particular melanoma, there's an area of central regression in the middle of the lesion. And superficial spreading melanoma, if caught early, can have a good prognosis because it often has an early horizontal growth phase of atypical melanocytes, which is confined to that dermal-epidermal junction, and so can potentially be excised with margins and have a good prognosis. The next subtype is nodular melanoma, and this image might look familiar to you because it's the melanoma we did the histological clinical correlation for earlier, and it looks exactly like what it sounds like. It essentially contains a raised area, a raised pigmented area that looks like a nodule. And unfortunately for these types of melanoma, there's a poorer prognosis usually than the superficial spreading melanomas. And this is due to the fact that there's often an early vertical growth phase of atypical melanocytes into the underlying dermis. The next subtype that I've brought up here is a lentigo maligna melanoma. And these often appear as pigmented macules, oftentimes in the elderly. And they can be very insidious, but if they're caught early, they can have a good prognosis because they, like the superficial spreading melanomas, also have an early horizontal growth phase. And then finally, the last main subtype of melanoma is the acral lentiginous melanoma. And acral simply refers to the fact that these melanomas are found on acral surfaces, like the fingers, the toes, the feet. the hands, or even the nail beds. And in this case, the melanoma that's being highlighted here is on the bottom of someone's foot near the individual's heel. As you can imagine, these types of melanomas, given their unique location, can be easy to miss. But one point to recognize epidemiologically is that it turns out in African and Asian populations, the proportion of melanomas that are acral is much higher than in any other population. So especially for individuals from these populations, it's important to screen for acral melanomas. And so with that, we come to the end of our video, and I hope now you feel a little bit more confident distinguishing benign from potentially more malignant pigmented lesions, and you're also able to appreciate the clinical histological correlations for melanoma.